Okay, thank you very much. As introduced, I'm Dr. Gerald Mataruka from Wits University. Um, this morning I'll be presenting on upper urinary tract trauma. My colleague, Dr. Janowski, will present lower urinary tract trauma. Okay, so in terms of epidemiology, 10% of all trauma involves the genitourinary system. There was a study done at Peter Maritzburg, which showed similar epidemiology statistics compared to worldwide. 1.1 to 5% of these of genitourinary trauma is traumatic renal injuries. There is a predisposition for males for genitourinary trauma with a ratio of 3:1, more common in males. Genitourinary injuries are rarely isolated and are often overlooked. Except for high-grade renal trauma, genitourinary trauma is rarely fatal. So I'll discuss briefly adrenal trauma. So adrenal trauma is quite rare and is a scarcely reported injury with an incidence of between 0.3 to about 5%. This usually results from blunt and high-impact thoracoabdominal trauma. It is rarely found in isolation and is frequently found with other injuries of the liver, the kidney, and spleen injuries. The right side is more affected than the left in about 70% of cases, and this is due to anatomical differences with the right adrenal gland being closer to the spinal bone structures, and then also as well due to the drainage of the right adrenal into the IVC. So if there is a compressive IVC injury, the right adrenal gland is at risk. In terms of renal trauma, so the kidneys are the most injured genitourinary organ. About 1 to about 5% of all trauma patients, and in about 8 to 10% of patients with abdominal trauma do get renal injuries. And men between the ages of 20 to 39 are the population that is most affected by renal trauma. Renal injuries in the pediatric population account for about 3.5% of all pediatric genitourinary injuries. And in children presenting with blunt abdominal trauma, about 10% of these children will have renal injury. So renal trauma, so patients that have pre-existing renal conditions are at an increased likelihood of sustaining renal injury, even with low velocity impacts. So for example, kidneys that are hydronephrotic, kidneys with stones, kidneys with cysts or tumors are more susceptible. And the reason being is fluid-filled incompressible compartments, such as hydronephrosis or cysts, they are more likely to amplify the force of the trauma and result in injury. So our genitourinary trauma can be split into blunt and penetrating. So in terms of blunt trauma, this is usually due to high energy collisions, such as from motor vehicle accidents, falls from height, activities such as horse riding, skiing, snowboarding, and other contact sports. So as we know from anatomy, the kidneys are suspended from the renal pedicle, and without other firm attachments. So this makes the kidneys susceptible from rapid deceleration injuries or whenever there is a direct blow to the flank area. Vascular pedicle injuries can be, vascular pedicles can be stretched during rapid deceleration, resulting in injuries to the artery of the vein that can lead to thrombosis. In terms of penetrating trauma, so this is commoner in younger patients. There's a higher rate of associated injuries. Patients who've undergone penetrating trauma receive more units of blood in the first 24 hours after admission, and interventions after penetrating trauma is much more common compared to blunt trauma. When it comes to penetrating trauma, it's very important that we get the details of the weapon that was used to inflict the injury, as well to examine closely entry and exit wounds, as this may help to determine what injuries to suspect. So it's important, for example, if you've got an injury in the anterior axillary line, you'd be suspicious of an injury to the renal hilum or the pedicle. And when you've got a wound near the posterior axillary line, you're more suspicious of injuries to the renal parenchyma. This is a slide taken from the study that was done in Pietermaritzburg in the year 2020. So they looked at patients that had traumatic renal injuries. So out of 223 patients that were studied, as you can see, so blunt trauma accounted for about 56% of those patients, and majority of those were from motor vehicle accidents. And then penetrating trauma was about 43%, with an almost equal split between gunshot wounds and stab wounds. And then the diagram on the right shows the distribution of the injuries across the different grades. This slide here is put to show how pediatric kidneys are more susceptible to injury when compared to adult kidneys. The reason behind this is your pediatric kidneys, they're relatively larger when compared to adult kidneys. The rib cage in children lacks ossification, and this makes the kidney more vulnerable. There is decreased musculature in children in terms of your back musculature, and also the abdominal muscles are thinner in children. Pediatric kidneys have less perinephric fat, which is protective in the case of trauma. And other features such as fetal lobulations make pediatric kidneys more susceptible. So the American Association of Surgery and Trauma came up with a classification system to grade renal injuries. These injuries are graded from grade 1 to grade 5. So grade 1 is a renal contusion where patient will present with hematuria but with normal urological studies, or it's a non-expanding subcapsular hematoma without any parenchymal laceration. Grade 2 would be a laceration less than 1 centimeter, or would be a non-expanding perirenal hematoma that is confined to the retroperitoneum. Grade 3 would be a laceration more than 1 centimeter, but is not extending to the collecting system. Grade 4 is a laceration that is extending to the collecting system, or there is an injury to the main renal artery or vein with contained hemorrhage. And a grade 5 injury would be a completely shattered kidney or an avulsed kidney, or there is a avulsion of the renal hilum with devascularization of the kidney. So this grading system is a very powerful predictor of clinical outcome. It's been shown that the grade directly correlates with the need for intervention. About 80% of high-grade renal injuries, which is grade 3 to grade 5, are managed expectantly or with conservative or minimal invasive approaches. Your nephrectomy is your most common surgical intervention following renal trauma. And as you can see, the rates of nephrectomy increase with increased grade, with up to 62% of grade 5 renal injuries undergoing nephrectomy. Penetrating trauma is an independent predictor for nephrectomy, with 19% nephrectomy being found in penetrating trauma compared to 6% in blunt trauma for the same grade of injury. The reason behind this is a debate on whether it's because of the more severe injury pattern associated with penetrating trauma, or merely because there might be a higher incidence of surgical exploration after penetrating trauma, which in itself increases the likelihood of nephrectomy. This is just two slides, one axial CT on the left showing a grade 1 hematoma of the left kidney, and the coronal section of the right kidney showing a shattered kidney on the right. So ureteral trauma. So the ureter is the least commonly injured genitourinary organ. About 1 to about 2.5% of all genitourinary trauma is associated with other injuries in most cases. About 5% of penetrating abdominal trauma cases, a ureter is involved. Ureteral trauma is more common in younger population. And blunt trauma, when it comes to ureteral trauma, the injuries tend to happen at the ureteric pelvic junction. This is more likely in children and in cases where there's high energy deceleration. The rate of iatrogenic injuries following gynecological procedures is noted to be about 0.2 to about 7.3 per 1,000 gynecological surgeries. I'm sure many of us would assume that number to be higher. So in gynecological ureteral trauma, about 80% of the injuries are pelvic ureters, and TAH is the biggest culprit in terms of the procedure, with myomectomy, cesarean section, and ovaryectomies being implicated as well. So when should we suspect ureteral trauma? So in patients that have complex abdominopelvic traumatic injuries, patients that have complex pelvic or vertebral fractures, where the mechanism of injury involves rapid deceleration, or when the trajectory of the penetrating weapon is near the ureter. And some of the signs suggestive of ureteral injury on imaging would be contrast extravasation, absence of contrast distal to the suspected zone of injury, or ipsilateral hydronephrosis. So the AAST also has got a grading classification for ureteral injury, graded 1 to 5, with grade 1 being a periureteral hematoma. Grade 2 would be a laceration that involves less than 50% of the circumference of the ureter. Grade 3, the laceration is more than 50% of ureteral circumference. Grade 4 would be a complete laceration with less than 2 centimeters of devascularized tissue. And grade 5 would be a complete laceration with more than 2 centimeters of devascularization. So in your evaluation, it is very important to follow ATLS principles and to conduct primary and secondary surveys. In your primary survey, genitourinary injuries may present as hypovolemic shock. It is important to note that in children, unlike adults, they are able to maintain their blood pressure even in the absence of hypovolemia. So blood pressure in children is an unreliable predictor of renal involvement. Patients can also present with minimal to no physical examination findings. If you do find physical examination findings, some of the signs you may find may be flank ecchymoses, abrasions, fractured ribs, and abdominal flank and tenderness with abdominal distension. It's important to note that these findings are non-specific. And then part of your evaluation, important to conduct urine analysis, hematocrit, and also baseline creatinine. So what are the indications for imaging? So patients that present with visible hematuria, patients presenting with microscopic hematuria with a decreased systolic blood pressure, patients that have major associated injuries, or if you're suspicious of injury based on the mechanism, such as rapid deceleration injuries, or if your trajectory in penetrating injuries is suggestive of genitourinary trauma or renal injury. So the imaging commonly performed, so your EFAST is routinely done to identify blood within the peritoneal cavity. When it comes to retroperitoneal fluid, EFAST has got a low sensitivity. CT is the gold standard investigation for visceral imaging after blunt trauma. And on your CT, on your arterial phase, you may identify vascular injury or the presence of active extravasation of contrast. Portovenal phase will help to demonstrate parenchymal contusions and lacerations. And your delayed phase helps to assess the renal collecting system and ureteric continuity. MRI may be used to diagnose renal trauma in patients that are pregnant or in cases of iodine allergy. And it's important to note that MRI is not routinely used. In children, there's a debate on what is the best way in terms of obtaining imaging. Some centers rely on the presence of hematuria, which is defined as more than 50 red blood cells per high power field. There have been reports of significant renal injuries that can manifest with little or no blood in the urine. So that may be a problem with such an approach. Other centers recommend imaging of the urinary tract with any degree of hematuria following significant trauma. So from the EAU, the recommendations is to use imaging in all children who have sustained blunt abdominal trauma with any level of hematuria. And then also they recommend using spiral CT with delayed images for scanning for diagnostic and staging purposes. Your intravenous pyelogram. So this may be useful in patients that are taken for emergency laparotomy without undergoing a CT scan. So 2 mL per kilogram of intravenous contrast is given, and this helps to assess the degree of renal injury, but more importantly, it also confirms the presence of a functioning contralateral kidney. The false negative rates associated with IVU are between 37 and 75%. In terms of follow-up imaging, so routinely repeating CT imaging after trauma is not recommended. A follow-up CT scan should be performed in patients that have deep renal lacerations who are undergoing observations who may present with fever, worsening flank pain, a falling hematocrit, or increased abdominal distension. In terms of your management, so as I've mentioned, important to follow ATLS principles. You need to identify and treat the immediate life-threatening injuries first. So when you assess your patient, you'd follow the ABCD approach. And you want to consider activating a massive transfusion protocol in patients who present with shock. And patients that are unstable want to be expedited for laparotomy. And patients that are stable with blunt or penetrating abdominal trauma and without any indication for urgent laparotomy should undergo imaging. So non-operative management. So due to improved imaging techniques and validated scoring systems, it's been found that there's improved outcomes with non-operative management. The majority of hemodynamically stable renal injuries are managed successfully with the non-operative approach. Selective treatment with interventional procedures in radiology has also reduced the need for surgical intervention. And surgical exploration has been shown to inevitably lead to nephrectomy in almost all cases. So due to your kidneys being confined in a retroperitoneal location, there's an innate tamponade mechanism that helps to control excessive bleeding or urinary extravasation. During surgical exploration, when your gerotal fascia is entered, the hematoma is no longer contained, and this may lead to more bleeding and may result in nephrectomy. Non-operative management may be considered even in patients who are hemodynamically transient responders. And isolated urinary extravasation is not an absolute contraindication to non-operative management in the absence of other indications for laparotomy. So in terms of expectant management, so we observe the patient and the patient is under bed rest, need to consider DVT prophylaxis with stockings or low molecular weight heparins. You need serial hemoglobin check. After your patient has received initial antibiotics at presentation, the indication for continuing antibiotics is governed by the injury grade, and patients that have urinary extravasation are usually kept on IV antibiotics. And you follow up, you repeat follow-up imaging as indicated, and no renal related interventions. There is no endoscopic or minimally invasive or open interventions are performed under expectant management. Obviously, if the condition of the patient changes, you may need to change the approach. In terms of conservative management, renal angioembolization or renal vascular stent placement can be done. This helps to decrease surgical exploration and nephrectomy. Renal angioembolization is successful in up to about 95% of grade 3, 89% of grade 4, and about 50% of grade 5 injuries. Renal artery angioembolization has a lower complication rate when compared to surgery. And your indications for angioembolization in hemodynamically stable or stabilized patients includes patients with active contrast extravasation, patients with pseudoaneurysms or arteriovenous fistula, or patients that have non-self-limiting gross hematuria. Endovascular selective balloon occlusion of the renal artery may be used as a bridging therapy whilst undergoing definitive hemostasis. And endoscopic or percutaneous procedures such as ureteral stenting or nephrostomy tube or drain placement may be done to manage large urinary extravasation and collections. In terms of surgical management, so your open operative management, so the interventions that are commonly or performed under open surgical management would include nephrectomy, partial nephrectomy, renal raphy, and renal packing for bleeding control. And laparoscopic and robotic procedures may be used. However, this is rarely done in the cases of acute trauma. So what are the complications of upper genitourinary injuries? So they may be divided into early or late. So your early complications would include bleeding, infection, sepsis, perinephric abscess formation, urinary fistulae, hypertension, and urinary extravasation or urinomas. Some of your delayed complications would be bleeding, hydronephrosis, stone formation, chronic pyelonephritis, hypertension, arteriovenous fistulae, and pseudoaneurysms. So what are your predictors for nephrectomy? So the statistically significant predictors that have been found for nephrectomy are the grade of the renal injury and also in penetrating mechanism of injury. There are other surrogate markers which may help to indicate patients that may need nephrectomy, such as patients that are shocked, patients with tachycardia, patients receiving blood products, and patients with metabolic acidosis or other injuries. So this is an algorithm taken from the EAU guidelines in patients that present with suspected renal trauma. So the initial step is to determine whether the patient is hemodynamically stable or unstable. If the patient is unstable, important you resuscitate as per the ATLS principles, and patients may undergo emergency laparotomy. And at laparotomy, if you're suspicious of a renal injury, you need to explore for renal injury. In patients that are stable, and these may be divided into presenting with no visible hematuria, or patients presenting with visible hematuria. Some patients with no visible hematuria may undergo just observation. However, in patients where you are suspicious of renal injury based on mechanism, or if there is suspected other injuries, it is recommended that the patients undergo CT imaging. And your CT imaging, then you divide your patients into those that have no active bleeding, and the grade 1 to grade 3 may just undergo observation. The grade 4 to grade 5 patients would undergo observation. You may want to repeat imaging if there's an indication, and if there's persistent urinary leak, consider a nephrostomy drain or a double J stent insertion. Patients that have active blush on CT, these patients could undergo angioembolization. And if you're in a setting where you don't have angioembolization, or patient has failed angioembolization treatment, you may consider renal exploration. In terms of managing ureteric injuries, so patients that have been taken for laparotomy prior to obtaining imaging, they should have their ureters mobilized and inspected for injury when suspected. Ureteral laceration that is discovered should be repaired in patients who are stable. In unstable patients who are undergoing damage control surgery, the definitive repair of the ureter is delayed up until the point is hemodynamically stable at a later stage. Contused ureters should be managed with ureteral stenting or resection and primary repair in selected patients. For your distal ureteric injuries, ureteroneocystostomy is performed, and patients with proximal injuries, end-to-end ureteral anastomosis over ureteral stent is performed. So these are some of the references I have used in my talk. Thank you.
Thank you. Thank you very much, Dr. Mataruka, for your talk this morning on upper urinary tract trauma. Do we have any questions from the crowd or from the floor? We got one question from Professor Kessler.
No, it's just the thing about final urinary Hi, it's just a more statement about the patients that have got a ureteric injury in the damage control setting. So it's very difficult if you tie the kidney off to then send them down to the suite for a perk, especially if they're unstable. So what we often do is we do a ureterostomy inside. We literally just put a ureteric catheter or a long feeding tube into the ureter, tie it with a purse string. We don't mobilize the ureter and bring it out through the skin. And then when you go back, you can very easily do your repair. And it often gives you the opportunity to then chart urine output and things like that, which you can't do if you've just tied it off.
Thank you very much for that, Prof. But sort of just a comment regarding the grading for renal injuries. I've been sort of back and forth when you look at the AST grading, and it used to be a grade 4 was a segmental artery injury in the kidney, and I see it's now a main renal artery or vein, but I think the key word there is that it's a contained hemorrhage. So just if you can just confirm that is the latest grading system, that it's the main renal artery and vein and not a segmental. Is that correct? Dr. Mataruka?
Yes, I'm here. Yes, so as far as I'm aware, I stand corrected though that it is a main renal artery. That is how I found it when I was preparing this talk.
Yes, yeah. And then we also see quite often when there's a reported high-grade vascular injury that do you think it's reasonable to sort of book the patient for an upfront angiography and proceed to sort of embolization, or is in your department or your facility, do the interventional radiologists first prefer to do imaging and then Because I feel it's a high dose contrast, double dose in a patient that's already got a bit of a fragile kidney. What is your guys' practice? Do you guys book them for an upfront angio and proceed, or do you first need to confirm it?
So the majority of the interventional radiologists in our setting or in our units, they tend to prefer to have angiography, CT angiography done prior to them performing these procedures. So, like you said, it is a double dose. And then there is issues with interventional radiology in terms of being available. So after hours are really difficult to have them available. They're not always available. So that's another challenge we have sometimes with interventional radiology.
Yeah, I think that's a bit of a global issue. Yeah. Yeah, Prof. Kessner just made a comment that that's such a valuable resource that if they're not available, patient almost inevitably have an nephrectomy if they aren't available. So important to have that.
Thanks for a very comprehensive talk. I think one of the controversies has been whether one should investigate somebody for renal trauma, stage them with a CT who's got a non-visible hematuria. And it was Jack McAninch from San Francisco that recommended after 1,000 cases that the value of staging in adults for non-visible was very small. So that crept into the guidelines then that we don't investigate non-visible hematuria. But the theoretical argument applies in kids that we should, where we've got non-visible hematuria. And we reviewed our series of over 100 cases of suspected renal trauma, and particularly those who had non-visible hematuria, the pickup was tiny, despite all those theoretical concerns about why kids might be more prone to blunt trauma. So the guidelines haven't accepted that, and it's probably just in our series, but it would appear the pickup rate in kids remains quite low.
Thank you for that, Prof. If we do not have any further questions from the floor or the chat, I'm going to thank you, Dr. Mataruka, for your talk this morning. It was excellently put. We can probably